Hello, my name is David Wilson. I'm a musculoskeletal radiologist based in Oxford. The topic for today is osteonecrosis. The condition of osteonecrosis is essentially death of bone, in simple terms. It's caused by reduced or interrupted blood supply. It means that there's damage to the vessels, compression of the vessels, blockage of the vessels, which could be due to disease of the arteries, thickening of the blood, or coagulation, clotting. So we're going to go through that in a bit more detail and talk about what causes this condition, but those are the big headings that I'm going to use to describe the etiology, the cause of the condition. It occurs between the ages of 30 and 50, and it affects about 50 per million of the population. So it's quite common, and in most orthopedic hospitals we'll see several cases a month. The causes can be divided into these subheadings that we've just described. Damage to the vessels may be due to a physical problem, for example, a fracture of bone, a dislocation of a joint, an operation on that bone, perhaps an osteotomy cutting across the bone. Radiation is causing damage by vasculitis, scarring of the blood vessels. Cold, frostbite, can cause damage to bone because it freezes and damages the vessels. It might be primary artery disease that causes vascular damage. Polyarthritis and polyarteritis, lupus erythematosus are common causes, and alcoholism, and that's through fat emboli from the liver, blocking vessels and damaging them. If we think about other mechanisms that fit into this category, we might consider here, for example, a subcapital fracture of the hip. The blood supply to the femoral head is principally through the neck. The vessels run along the neck and they run up to the femoral head. The bone is damaged because the vessels are interrupted. If you break your hip further down in the intratrochanteric area, it's less likely to damage the arterial supply, but in this area, it places it at great risk. So the consequence may be that the femoral head becomes sclerotic, it slips off, as it has in this case, looking at the radiograph on the right-hand side. Blood supply is interrupted, and eventually sclerosis and fragmentation will occur. You might get insufficiency fractures. Now, these are fractures caused by softening of the bone. Here's a patient who has insufficiency fractures elsewhere in the body due to osteoporosis, and she was taking bisphosphonate, which is a drug which we term an antiresorptive. It's intended to stop the bone metabolism so that the bone becomes harder. It's not being resorbed as much as usual. It's a switching off of the osteoclasts. The problem is that the bone then can become very brittle and hard, and in the jaw it might become thickened and then start to break because of its hardness. I liken it to a piece of rock from the seaside. If you take a piece of rock, it's very hard, chewing, eating sweet rock. If you then break it across your knee, it snaps into multiple places. Here we can see that the jaw on the CT examination has got thickened layered periosteum. It's thickened, but it's also fractured in a way which is quite unusual. It's fractured in a transverse plane across the mandibular condyle. It's fractured at the front of the condyle. Notice also that this jaw is much thicker. So this is bone which has become artificially hard and has broken as a result. What also happens is that the poor blood supply in this area leads to osteonecrosis. So these are fractures which lead to osteonecrosis. Only this morning I've just seen a patient with this condition. This is what used to be called spontaneous osteonecrosis of the knee, and we now recognize as quite simply an insufficiency fracture occurring in the subchondral bone of the knee. The lady I spoke to today has an injury which was caused by getting out of bed. When she got out of bed, suddenly her knee started to hurt. And an MR scan shows the edema. It shows the subchondral fracture. It sees a line on the condyle, and it also shows extensive edema in that area. Compression of vessels is the next subcategory of why we might get osteonecrosis. If we fill the bone marrow with abnormal tissue, for example in Gaucher's disease, or in some of the Ganglioside lipidoses, then that can cause pressure on the vessels and reduce their blood supply and cause infarction and death of bone. There is an argument about the condition known as transient osteoporosis. This occurs very commonly the patients are in their later stage of pregnancy, but it may occur in men, so it can occur spontaneously. We don't really know the primary mechanism. It's termed transient osteoporosis because we see on the radiographs thinning of the bone, but it is transient, it repairs. It's associated with the later stage of pregnancy, but it also produces severe pain. In many, it will spontaneously recover, but others believe that it actually can go on to classical osteonecrosis, and the linkage between the two is not fully understood. Another reason why we may get increased intraosseous pressure is because the patient's taking steroids, and we think that the enlarged fat cells within the bone marrow causes pressure, reduces the blood supply, and therefore increases the risk of osteonecrosis of bone. So that's a case of transient osteoporosis. We can see the edema in the bone, seen as high signal on the MR. There's two patients here. I'm giving you another example. It has this flame-like appearance of the white edema of bone running down the femoral neck. Here's a youngster who took steroids at the age of 14 for 3 weeks and developed spontaneous osteonecrosis. Here, the increase in the fat cells, we believe, causes reduction in blood supply, and we can see the area of abnormal bone, which is running over into the femoral head. Notice that there is edema around a halo of a scar, effectively an area of low signal on T1 and the low signal on T2, within which is the dead bone, and the bone edema around it is reacting to it. We'll come back to those signs a little more later on. Now, the classification of osteonecrosis of the femoral head, the best one, and the one that I would suggest you refer to, is by Arlet and Ficat, and they described a series of imaging signs and clinical associations. Normal is when everything is normal, there are no symptoms. If the conventional radiograph is normal but the MRI shows edema and a nuclear medicine study is active, pain in the groin, in other words, we've just got bone swelling, they would class that as grade 1. When we start to get damage to the bone, and we get lytic areas on this conventional radiograph and sclerosis in bone, and the MR shows this geographic pattern that we're looking at in this case, the patient almost certainly will have pain and stiffness. That's a grade 2. Grade 3 is when we have the crescent side. We're beginning to form an area under the bone surface which produces a line. The bone starts to collapse, and we might argue here that this one is beginning to collapse. There's a slight contour change, and we'll see that also on MR, the same sides, and they will have pain and radiating pain down the leg, and almost certainly stiffness in the joint. Grade 4 is the final stage, when conventional radiographs and MR show collapse and secondary degeneration, at which point the patient will be considerably disabled by this condition. Here's an example of a grade 4 osteonecrosis occurring in the talar dome. There is fragmentation of the surface, there's flattening of the surface, there's contour change, there's extensive edema, there's now beginning to be narrowing of the joint space and secondary degeneration. Osteonecrosis is a severe condition which is very disabling and may need surgery to treat it. Blockage of vessels. Well, this is, again, a way of reducing blood supply. It occurs in conditions like sickle cell disease, where the sickling phenomenon at reduced oxygen tension, that's when you go up in an aircraft or go to altitude, can cause the blood vessels to block and infarct. Lymphocytosis is another potential cause of fragile red cells. Coagulation disorders, such as diffuse intravascular coagulation, pancreatitis, dehydration spelled hyperviscosity syndromes, may cause abnormal coagulation. And finally, but not least, is caisson's disease. The picture on the right is a caisson. This is how you engineer and work underwater. You pump pressure into chambers within it to keep the water out, and you can then dig away, dig your tunnel, dig your cavity. This was originally tried by Isambard Kingdom Brunel, who in Victorian London dug a tunnel across the Thames underneath the water, which is very silty and muddy at the bottom, and by putting pressure into the tube, he was able to allow the engineers and the workers to dig the tunnel. The reason why people working in this environment get caisson's disease is because when they come out of the tunnel, they should decompress for a period of time, bringing pressure down. but very often they don't. They rush off and have a few beers, and then the pain they get from the bends or nitrogen narcosis goes away. They don't cope with that, but they actually get bone infarction. And I've seen this in a number of people who've worked on a tunnel further down the Thames in Dartford, and also people who have come back from Hong Kong building a tunnel across the harbour. The radiographic signs that we see with osteonecrosis, from whatever the mechanism, at first is no abnormality. The bone is dead, but we see nothing, because nothing has changed to alter the structure. The pain is there, the disease is there, and it will deteriorate. Osteopenia comes later. It's very hard to detect because you need to lose a lot of bone in order to see it. So it may be there, and if we did a DEXA examination, if we looked in detail or quantitative CT, we might see it, but it can be hard to detect, and we very rarely recognize that abnormality. It's when the repair starts to take place, where there's sclerosis, and when the bone has weakened and it fractures and collapses, that we get fragmentation. And at end-stage disease, like this radiograph, then it's really degeneration we're seeing and collapse and fragmentation of the structures. And this was osteonecrosis occurring in the capitellum, which led to secondary advanced degenerative disease. The scintigraphic findings are essentially non-specific, and they don't really help us very much because they're not very specific to the diagnosis. Any disease affecting a joint can produce increased activity. The activity increases due to the repair process, which leads to the radiographic signs that we've just described, but the scintigraphic appearances are very non-specific, and almost anything affecting a joint, including arthropathy, including trauma, can cause the abnormality that you see in osteonecrosis. The late stages of osteoarthritis, again, are identical to osteoarthritis we see when it occurs spontaneously, with joint space narrowing, sclerosis, and eventually fragmentation of the head and collapse of the bone. We will see edema, and we'll see surface changes on MR. So here we can see a joint effusion, we can see irregularity of the femoral head, and we can see edema in subcapital bone. Exactly the same as you would see in osteoarthritis from whatever cause. Now, the MR signs of osteonecrosis are first and probably foremost bone edema. We saw it earlier in that patient with spontaneous osteonecrosis of the knee, not spontaneous, an insufficiency fracture, but it also occurs in all other varieties of osteonecrosis. The marrow is replaced by necrosis. Eventually, we get sclerosis, and it produces the geographic pattern, a sort of contoured pattern that you can see on this MR on the right-hand side. And then eventually, this fatty replacement of marrow. And notice on the stir sequence how the fat is suppressing and has become black in the central lesion in the tibia. So here's a case of osteonecrosis of the hip, and we'll just look at the MR findings. We can see that it's bilateral. We can see it's affecting both heads. This probably a longer time ago because we had sclerosis and less edema. Here is the sclerosis, the contour change. We can see the edema running down the femoral neck. So this edema down the femoral neck is a secondary response from the damage that has occurred in the femoral head in this location, or on the opposite side here. Notice that we're seeing a crescent sign, a line running under the bone surface here. And on this side, we can see little areas of edema in pockets and possibly hemorrhage and necrotic tissue, producing fluid within the femoral head. Another way of measuring the amount of femoral head involvement is quite simply to measure the proportion of the femoral head that's affected by it. And here we'd probably be about 60-70% of the femoral head. You can draw a triangular shape, you can draw a line to the center of the head and work out how much articular surface is involved and how much is not. So MR is the technique of choice in assessing osteonecrosis. It's the most sensitive, it's the most specific, and it allows us to stage it. And therefore, conventional radiographs and nuclear medicine are ancillary techniques. Here's an intensive care nurse who developed these changes of osteonecrosis extensively through the femur and the tibia. We can see the geographic pattern, we can see the edema, we can see the fatty replacement starting to occur. We can see calcification occurring within the affected bone. So why is an ITU nurse developing this? Well, it's because she was stealing drugs from the drug cabinet and mainlining the heroin that she was obtaining from the intensive care. The reason why people who are addicted to mainline drugs, it's probably more to do with microemboli due to damaged material than it is due to to damage to blood vessels. Bone infarction will appear like this. We can see areas of edema, we can see areas of necrosis, we can see areas of sclerotic bone forming around the outside, and we can see the same thing on T1. Of course, the fluid within it, the necrotic area, will be high signal and T2 weighted images. So the low T1 might be due to hemosiderin or granulation tissue, or sclerotic bone, or a mixture, and that's why we get this geographic pattern and rings of different signal intensities. Marrow reactivation is a different disease, and this occurs typically in people with chronic disease, such as renal chest disease, heavy smokers, alcoholics. It's a non-neoplastic condition. It affects the marrow, which is hyperintense to muscle. In the neoplastic variety, it's more likely to be iso or hypointense to muscle. These are people who've actually got bone marrow infiltration. And this has got a similarity to bone marrow infarction, but the difference is that this is more generalized. It isn't affecting an area where an end artery is located. So when you're making this differential diagnosis, you need to think about where the bone has been damaged. If it's general, think about marrow reactivation. The condition of Legg, Calve, Perthes disease is interesting. This occurs in children, typically at the age of the patient I'm showing you, at about 10 years maximum, sometimes as young as 4. It's that sort of age group. We think that this is an osteonecrosis process caused in the growing bone, where there is a shearing effect due to soft bone, which is occurring in the subarticular region, and we can see the changes there. We then see the sclerosis and the fragmentation, which later on produces chronic deformity. And look at the femoral head on this side and the flattening of the femoral head in the same patient here. It's probably a similar process, but because the skeleton is immature, it happens in a slightly different pattern with deformation of the normal growth characteristics of the femoral head. Similarly, in a patient like this, who's developed pain in the wrist, a mature patient, we can see in 2002 that there was a sclerotic area within the lunate. Notice the ulnar is short, so this is an ulnar minus variant, and it's felt that this puts out normal biomechanical stress on the lunate as it impacts on the side of the radius, just here. So this goes on in 2004 to be more sclerotic, and you can start to see little lytic areas appearing within it, and then it becomes more sclerotic still. There's lysis within it, and we can see on the MR the areas of sclerosis and the areas of fatty replacement, and we can see some edema within the marrow as well. And this is so-called osteochondrosis of the lunate, or Kienbock's disease. It occurs in manual workers, probably because they're using machinery. We can see here it's led to an insufficiency fracture and a subchondral fracture. It's typically in the dominant hand because that's the one where the impacts will occur. Negative short ulnar is associated, and trauma may be the etiology. The end mechanism is osteonecrosis, but the mechanism here is one of repetitive trauma in most cases. Other conditions you might think of in differential diagnosis. Here we see a bone edema in distal femur with insufficiency fractures in a patient aged 26. Well, spontaneous insufficiency due to osteopenia and osteoporosis would be very rare in this age group, but in this patient it had a predisposition. She had Osteogenesis imperfecta and was also pregnant, and maybe the changes in estrogen has actually caused part of the change. But here we've got fractures which look typical of the osteonecrosis that we see in other mechanisms. So it's probably the same end mechanism, although the bone was dried out to start with. Red marrow reconversion, here's a diffuse variety in the sort I was talking about earlier, where we have a low signal on T1 weighted images when it should be white. Marrow infiltration can be due to many causes, and this is too general really to be just a focal loss of blood supply. In a patient like this, where we can see an abnormality with a geographic pattern within the ilium, look at the sclerosis around the outside, that's not a bone that is typically affected by osteonecrosis. Those affected by osteonecrosis tend to be the round bones, the end of the femoral head, the end of the femoral condylus and knee, the humeral head, or the capitellum. This is a flat bone. And when we look on MR, which we know is the definitive technique for assessing osteonecrosis, we see a massive soft tissue mass associated with this, which you would never see in simple osteonecrosis. And this is a tumor, a Ewing sarcoma the left ilium. Here's a patient where there is sclerosis in bone, but this time it is enlarging. It's producing a great big lump on the side, which again we would not see in osteonecrosis. We might see the sclerosis in bone, but not that layered on the surface. And this is one of these rare conditions, on this occasion, meloriostosis. This is probably a genetic abnormality with mosaicism. And part of the body has a different gene, and the DNA abnormality has already been identified in this disease. It's very painful. Bone islands, which we see very commonly, which are foci of a compact bone, don't have edema around them, don't have liquefaction, don't have marrow replacement in the center of them. This is a benign bone island, which are common and can be effectively clinically dismissed. So my conclusion is that osteonecrosis is common. We will all see it in our clinical and radiological practice. The causes are reduced blood supply. Think about vessels being disrupted, vessels being compressed, and vessels being blocked. And that leads you into the very wide differential diagnosis of the cause of the osteonecrosis. Insufficiency fractures and osteoarthritis may present as osteonecrosis. Their mechanism is different, insufficiency fractures being most commonly caused by osteoporosis, but the endpoint is osteonecrosis. Thank you very much indeed.